Just 1 moment to finish this. All right. Good afternoon and welcome back. It's a much nicer day out, and we will be getting out a bit early today so that you can enjoy the good weather. Today is day 2 of our presentations, so we'll be hearing from the remaining folks who are sharing the work that they've developed over this class. Before we get started, I did want to give a quick blurb for those of you that are returning next fall and planning your courses. I just got in touch with Rory Becker in anthropology, who's offering a new course that'll be online called Quantitative Methods in Social Sciences. So a lot of you have kind of done research related to sort of data and quantitative work on health disparities. So if it's an area that interests you, I definitely recommend taking that course. Rory has also offered, if you're interested and want a syllabus or other material, to get in touch with him. It's ANT 395. So thought it might be relevant to some of you that are interested in similar types of research projects and work. So seemed like kind of a cool opportunity coming up. All right. So we heard from the first half of the health disparities presentations last class. We had 7 great presentations, and we have our final 6 today. So we'll be going in order through Fatima, Izzy, JJ, Emily, Christy, and Kiana. As a reminder, I talked last class about the quiz that we'll be using. The quiz is for this week, asking you to pick 3 of the presentations and just to take some notes on what you noticed and what you learned through that presentation. So just as a reminder, you can complete that quiz on Canvas. I'll also have the recording available after class, and I encourage you to just take some notes on a few presentations that stand out to you if you haven't already done so for Monday's presentations. As a reminder about presentation format, there are 6 to 8 minutes for you to present. I'll let you know when you have 4 minutes remaining, 3, 2, 1, and then when you're done. Again, as long as you're in the 6 to 8 minutes, so at about 2 minutes remaining, you're in good shape. I believe I have all of your slides and material downloaded and ready to go, so we'll move along the line there. And again, just as a reminder, please make sure your phone is silent or off, and wait for a presentation if you need to step outside or do anything like that. Also, just screen cap this so that I have it. Again, that quiz is just asking you to take notes and observe some of the things that stood out to you on these presentations. And then after our presentations today, when we come back next week, we'll be talking about the next assignment in the course, where I'll ask you to analyze and look at a health communication campaign. And then we'll also talk about health and science policy. So we have some fun things coming up in that regard. So bear with me as I go through these presentations so that I can get pulled up. Okay, great. So we will start out here with health disparities within Hispanic culture. Awesome. Yes, so you can use either this button here to click or the arrows to move it.
I move the camera instead of like
showing
my face.
You're also welcome to
okay, it's the door or the window. All right, so my project and study I've been working with health disparity within community culture, which is basically dealing with health literacy within the United States, the way to improve their communication by using technologies, e-health, m-health, and telemedicine and robot doctor to improve their health literacy, because in the Hispanic culture, it's really low because they don't understand English at all in the United States. So the introduction here is an outline how we're going to talk things through how the struggle of understanding literacy within Hispanic culture and targeting the groups that leads towards lower literacy, which can be caused by living in poverty, can also affect having low education levels, race of ethnicity, that was a typo, and disability. And also we're going to talk about a research that has been affected towards targeting Hispanic and women who have been affected with HIV and STI because they have low income of literacy, since they don't know that much education about health protection and sexual assault as well. And also going to be some like survivors who talks about how they can educate others as well about having HIV, and also how to have a different outcome as well. And also how to improve with the low literacy, building like good connection with translators or even health technology can be discussed further on. So basically with low health literacy is dealing with like Hispanic culture has trouble understanding the health literacy with their own primary provider, also providing them with information that has been confused for patients to understand, even though the provider explains it the easiest way as possible. But the patient still feels clueless about the provider or what it's talking about because they have a minimum of experience of speaking English. And also I've been experiencing with my parents how they are like non-speaking English speakers. And basically I've been dragged onto their appointments to translate for them as well, even though I'm not certified to be a translator, but basically if I go to like a clinic that's easy about an eye doctor, I can translate about stuff like that. But if it's towards like a hospital with higher like literacy levels, I will understand what they're talking about since I am starting to be in that profession, but I'm not confident to make them like feel more worried of how I'm understanding other stuff to having in Spanish culture. So the patient will feel basically clueless about the higher risk health problems such as transmitted disease, cardiovascular, mental health, and cancer, which can be impacted by various outcomes that have lower literacy. And here's a study between the U.S. Department of Health and Human Services that can be caused with low literacy by living in poverty, can impact with low education, race, ethnicity, age, and disability. That can be a disadvantage between the patients and the provider that can cause with cultural and language barrier for the patient to understand what health literacy, which is also known as CLAS, which is spelled as CLAS, which is known for cultural, linguistical appropriate services that reduces the health disparity between the provider and the patient as well. And the research I want to study on it between how it impacted in Hispanic cultures by targeting women who had transmitted diseases such as HIV and STI. For example, the minority of a Hispanic culture had a higher percent of getting STI between the age of 15 to 19 years old, getting sexual or physical abuse of being high rates of STI, and which they have a low lack of levels of acknowledgement of preventing transmitted disease later on. In the research, it does spread awareness, which you can see right here on April. They do celebrate the STD Awareness Week to provide any like campaigns as well as educate other schools and middle schoolers about how to prevent sexual awareness of diseases. And the survivors can also influence the students with minorities by teaching them with the consequences of having HIV or the steps to accept the transmitted disease by the ways they can live with better outcome. And the ways to improve their health literacy is basically how the Hispanic culture is finding the connection with the patient who has language or cultural barriers, or they can reflect towards their belief affecting their, according to the Center on Diseases of Control Prevention, not all languages have the same in existence in their own languages, cultures, and not words and ideas can be easily translated or explained in their own languages, which is an experience, how I said before, how I've been working with my parents, translating the hospital to clinics. It's been a huge barrier between me and the provider as well, because basically we don't have the same acknowledgement how the main provider has it, meaning to one, meaning to another, because basically how the provider explains the diagnosis in like a figure of speech, can I simply like shorten into one word of what they have, basically, because it can be confusing for the translators as well, and also like for the patient to know what diagnosis they have is going on. And the way to improve that is basically when in the modern time, how we're using translators and health organizations that can improve their health literacy by providing translators who are certified and know, and know the connection with people with the same languages to build on the trust. And if a translator is not in town, they should also have a plan B, which is also going towards the health technologies we've been talking about in class later in the term, how we use mHealth, eHealth, and mHealth, mHealth, eHealth, telemedicine, and RoboDoctor. And basically with that, we can do is if the translator is not in town, the organization can use health technology such as RoboDoctor, mHealth, eHealth, and to translate the good information about the diagnosis and more about the information, because this method can receive good feedback to have monthly check-ins in the patient with needs within hesitation of our understanding. Because basically when I was job sharing as well, I didn't know those RoboCops, that person with the face. I don't know what, I was just like a vending machine that delivers like those sodas to you, like the one in Hope. I didn't do it before, but you know, on Instagram, which we have one now, but if you gotta know, this can walk themselves or the patient's health records instead of going to a doctor. Talk about how they're diagnosed with something, also the translator can use and also a provider as well. If we give them like a background check of which translator or doctor you're talking to make them more sure while talking through the screen. Because sometimes doctors who live in across the state help them translate about the diagnosis, but they can still help doing like virtual, like through Zoom or using one of the technologies as well for that. And overall, that's my study between the health layers with Hispanics, and that's my research about that.
Getting us started. I thought you did a really great job here of not only talking about health literacy disparities, language barriers, and similar related issues, but also in thinking about like technology or e-health, health, and so on, and how like a lot of the kind of health literacy issues, language barriers, and similar things kind of get magnified in a lot of cases, right? Where oftentimes we might think, okay, we use online ways for people to communicate, but it actually creates even more barriers. Like there's the comment you had where they were, somebody was talking about dialysis and they got the wrong thing, we're searching the wrong thing, right? So technology can be great for creating more opportunities to reach patients, but it also can exacerbate those problems. I think you did a good job here of highlighting some of the benefits as well as drawbacks of thinking about these technologies and disparities. All right, so second up, we have Izzy. So you're welcome, you can click and then use the arrows.
All right. All right, guys. So when I started this project, I wanted to go down the line of like prevention for like teens and stuff like that, but I shortly like realized that the disparity here was for people with addiction. So that was what my topic just ended up being. So just a few questions to get the wheels turning is, how does addiction affect the health and well-being of others? And who does addiction primarily affect? Because we know that addiction affects us physically and mentally, but it also affects like the relationships we have with care providers. So addiction can be defined as the need of a substance in order to maintain proper function. Although I will be focusing on alcohol and substance abuse, addiction can be nearly to anything, devices, actions, and even people. So I kind of got into this, like, what are you addicted to? And just some like common ones I think in this day and age might be social media, caffeine, digital devices, and I am an avid heyday addict, so I had to throw that up there. And according to the National Survey on Drug Use and Health, nearly 19.7 million American adults ages 12 and older battle substance abuse. Almost 74% of adults suffering from a substance use disorder specifically struggled with alcohol, and 38% of adults battled an illicit drug use disorder. 1 in every 8 adults struggles with both alcohol and drug use disorders at the same time. And one thing I just wanted to make an important note on is that yes, addiction does obviously affect the addicts, but it also affects the people who are in their lives, like their loved ones. So addiction across races, and I thought this was a really good sentence while I was doing my research, is addiction does not discriminate. It does not matter if you're 100 years old or 12 years old, black or white, male or female, addiction is coming after or is after everyone. So these statistics are from a study from 2019, and I chose these ones because they're about addiction as a whole and not just substance abuse or alcohol. So 60.1% of addicts are white, 18.5% Hispanic and Latino, 13.1% Black or African American, 5.9% Asian American, 1.3% American Indian or Alaskan Native, and 0.3% Native Hawaiian or other Pacific Islanders. Another major thing that I found in my research was that a major part of the addiction population comes from those of homeless communities, and 71.2% of homeless individuals confess that they have struggled with or do struggle with addiction, which once I get into like the cost of rehabilitation and stuff is pretty crazy. And something big I wanted to focus on was the stigma of addiction in media. Often in media, we see characters that portray the role of an addict. However, one thing we learned in this course is that not all people with the diagnosis are the same. So in media, addicts are often people of color, which like I said in the last slide isn't primarily true. Low socioeconomic status, violent behavior, homeless individuals, and basically they're just dirty, poor, stinky, and they can't support themselves. This stigma can lead to unnecessary suffering and more overdose, as well as poor declining health among addicts that lead to death via cancer, organ failure, and even poor mental health and suicide. These are just some examples I thought of off the top of my head. I don't know if you guys have seen Shameless, but I think it does a really good job depicting a very basic stigma of addiction. Addicts seeking help. So a great deal of stigma remains and provides an extra barrier to people seeking or asking for help that they need, as they suffer from unnecessary guilt and shame. Many healthcare providers don't want to deal with people suffering from addiction due to stigma. In short, stigma can lead to unnecessary suffering. So when I was reading about this, doctors love to see progress. So they want to go and, oh, you have a broken foot, I'm going to put a cast on it and send you on your way. But they will kind of avoid helping addicts because it's not an easy process, because the road to recovery is so long. And addicts struggle to seek healthcare due to fear of judgment and that stigma. No one goes to the doctor looking for a lecture, much like kids don't go to school looking for a lecture on drugs. And morally, this was probably incorrect, but I joined the little AA chat room just to kind of get some input on this. And one of them were saying that smokers fear the dentist like alcoholics fear care providers, because you can't really lie to yourself once you get some physical proof of the state of your addiction. So that is one reason. And then I wanted to talk about how to talk to an addict about treatment. So it's important to explain your role as a care provider to give them the help that they need for a healthy lifestyle. It's important to instill care over concern, like how can I help you? How should I help you? Not you need some help. Judgment-free tones are important. Make it the addict's conversation and let them guide it. They'll only tell you as much, they only want the help as much as they do. So it's kind of their conversation. And as we talked in class, much like with talking to people with disabilities, respect is very important. Don't talk down to an addict. All humans make mistakes, and you can remind them of that. Addicts are not seeking pity, they are seeking comfort and options, and it's the job of a healthcare provider to give that patient options. All right, so this is identifying and discussing drug use. So these are the steps that a primary care provider would use to identify substance abuse. So first you would ask drug history. How often do you smoke? How often do you drink? And after you get a sense of their relationships with substances, you would move on to identifying risk level, because being an addict puts you at a high risk for a lot of different things, much like anxiety and depression. And I'm not going to click on this just because of the sake of time, but this is a screening, an online screening thing that you can take, and it just asks you a bunch of questions about how often you use, are your family concerned about you, that kind of stuff. And then it puts you in a category of like a phase of addiction that you're in, and it puts you in touch with people that you can talk to that are at the same place. So kind of a good example of telemedicine. And 3 is to advise and provide medical advice about the patient's drug use. Notice how I said advice and not orders. So that might sound like, given what we've talked about, do you want to change your drug use? And if the patient is ready to quit, raise or assist them in efforts in finding ways to help them. And we're going to keep going. So substance abuse and rehabilitation costs. So like I said, 71.2% of homeless people are addicts, and that is the cost of rehabilitation is ridiculous compared to those statistics. So a detox is like the cheapest, and it would be $1,500. Inpatient rehab is $12,000 to $60,000. Outpatient can be anywhere from $5,000 to $10,000, and the medications alone are several $1,000s a year. So how can someone even go and get that help if they can't afford it? And rehab is covered by insurance, but not every individual has insurance. And I wanted to talk about AA because it is something that we see a lot in the media. But for those that don't know, AA is an international organization of peer groups that meet to support each other. Members meet regularly to discuss issues and concerns related to their addiction and support each other not only on triumphs, but relapses. So a few things about AA that I learned is that first, AA is free, so it's for anyone and everyone. It gives a major sense of community and support because nobody is there to judge because they've been in the same boat, if not now then before you. And it has open availability, so there are meetings everywhere and anywhere, and they're often in places of just neutral zones like churches and libraries. And I also found an app for this where you can be anywhere and you might need a meeting, you might have a trigger, and you can pull up this app and it'll take you to the nearest AA meeting. So I thought that was a pretty cool thing to find. And then last but not least, something about addiction is that there are programs not only for alcoholics, but there is also for narcotics, sex and love, and something called Al-Anon, which is for those watching their loved ones go through the road to recovery. And there are my references.
You did a great job here in applying and using a lot of the things we've talked about over the course of this class. I really like, for example, discussion of stigma and sort of portrayals of addiction in media, right? You had some good visual examples there, including, I noticed you had Rue from Euphoria in there too, right? And a lot of the ways that generationally depictions of addiction might impact millennials and Gen Z folks. I really like your use of supporting content here, including the example, right, of going to that AA chat and sort of seeing how there's this fear of going to the dentist that's confirming the experience of addiction. I thought that was a really great insight you brought in. And also just many of the sources, including sources that are designed to help people at different stages of addiction, I think are great at showing these specific communication strategies that we can use to address addiction and many of the kind of social stigmas and impacts that we see in how this is portrayed. So I thought you did a great job here of engaging with us on this topic and really getting us thinking about this in a communication context. So awesome work there. So we have JJ up next. JJ, I'm just searching for yours. Going to download it. There. Okay, and you're welcome to click with this, and you can use the arrows there as well.
Okay. So I decided to do my presentation on health disparities among ethnic minorities affected by IPV. So intimate partner violence against women is defined as an act or threat of physical and sexual assault perpetrated against women by their current or former spouses. It is a major public health problem in the United States. IVP is the leading cause of injuries to women between the ages of 15 and 14 and is more common than muggings, car accidents, cancer, all that combined. Women usually experience IPV are twice as likely to be in poor health as women who don't experience IVP. So approximately 4.2 million, which is 35% of women in the US experience rape, physical violence, and or stalking by an intimate partner at some point in their lifetime. And this is a chart from the IPVA Association, which has the multicultural, non-Hispanics, non-Hispanics Blacks, and non-Hispanics White. As you can see that the leading results for multiracial non-Hispanics is at 57%, followed by American Indian and Alaska Native at 48%, and so on and so forth. So IPV has been associated with multiple adverse physical and mental connections and health risk behaviors among women of all backgrounds. Comprehensive reviews of physical and mental health consequences of IPV reported that multiple health outcomes, including chronic pains, cardiovascular problems, gastrointestinal disorders, neurological problems, and for the mental, usually depression, PTSD, low self-esteem, and suicidal. So one cannot fully understand IPV and health disparities without examining in ways in which they intersect with race, ethnicity, gender, socioeconomic status, and other conditions. So for provider and patient barriers, you see a lot of lack of physical or physician training on IPV. There is a need for increase in training on IPV for physical physicians and healthcare professionals, particularly with a focus on addressing the impact of stereotyping on the quality of care. Also, there's a lack of screening tools and inadequate screening tools do not provide an assessment that considers cultural and societal influences. There's also stereotyping and labeling. Women of color experience several stereotypes and labels that discourage them from receiving assistance to deal with IPV. There's also a lack of cultural competence. Ignoring the challenges faced by different groups will also, denies and invalidates their experiences. As well as language barriers. It's not just the word that gets lost in the translation, but also the context of the word and the meaning behind the language. So for when a provider is explaining to the patient that there is a need for their health, sometimes they don't understand that because they don't think that being in a violent relationship is affecting their ability in health. So what patients and providers can do, they can help with seeking behaviors. So women of color often turn to informal services, providers to receive services before reaching out to formal providers. Stigmatization. So women of color may feel shame and embarrassed with regards of experience IPV because of the lack of information that's out there, prevalence to the IPV in the respective community. Also family secrecy. So providers have to understand that when women are in these types of situations, that they can't really just reach out from themselves because they're scared, or they don't have control of their finances. So women of color are encouraged to keep the business of the family within the family. That's why they usually have those barriers. So women experience IPV as twice as likely as more than poorer health than those that are not experienced IPV as a result of 21,000 hospitalizations, 28,000 emergency department visits, and 39,000 visits to physicians annually. Many of these health and disparities involve, different barriers. So one important component of both reducing violence and the health of burdens of those in the violence of role in healthcare providers is making sure that we detect these early on through screenings, and furthermore give the complex nature of IPV with a wide range of health consequences. So basically just letting these victims know that there is help out there, and we can do this by asking the right questions, being there, having those visits with them. A lot of, developing stronger tools, encouraging greater collaborations within the community, making sure that we have different agencies and campaigns out there, making sure that we're engaging in more intervention research, requiring cultural competence, increasing funded research, and definitely encouraging mentorship, making sure that we have that accountability and increasing healthy promotional campaigns. And I just wanted to show a few examples from different platforms like Facebook. We have support groups that are able to be a part of and talk about different situations and have that privacy. We had the Me Too movement on Twitter. And then also Instagram has provided different filters to be able to show that campaign in support of IPV and domestic violence and such. Yeah, here's my slides.
JJ, thank you so much for working us through what is, a very challenging and heavy topic, youth partner violence, including the kind of disproportionate impacts and challenges that you highlight among ethnic minorities is crucially important. I really appreciated the way that you focused on a lot of the barriers and factors, including financial barriers and the ways in which those impact power dynamics at IPV. I also appreciated at the end how you were highlighting some of the social media campaigns and ways that we've been able to use online communication to highlight, shed a light on, and also to suggest ways of addressing sort of the societal implications and stigma associated with that as well, right? Like I think there are a lot of misconceptions about IPV and assumptions about how survivors are the options they might or might not have to address that situation. So I think you did a great job highlighting how health disparities can impact the options available and strategies that can be used in response. So thank you so much for bringing us through this topic and helping us to think about this issue in a lot more detail. So our fourth presenter for today is Emily. And Emily, you can click here, and then you can also use the mouse.
I will be presenting about health disparities in birth control and informed consent. So informed consent has like three aspects. The patients must be like fully aware of the treatments, risks, and benefits. And then like the second one is that they should be able to like understand all the information and like make a responsible decision. And then like the third aspect is that they should like be able to know that they can like refuse participation or treatment at any time. And then the issue is that birth control has like many short and long-term risks, and then like the patient needs to know like the options. The populations impacted are like women who use birth control. They use birth control from like puberty to menopause, and menopause is like an age when women are no longer menstruating and they can no longer conceive. It's caused by like age and hormonal changes. The majority of women using birth control are 15 to 49 years old. Contraceptive methods vary, but I'll be talking about the oral pill. And then I feel like there's some serious implications with birth control and having like pre-existing medical conditions that can like worsen the risks. And for example, if a patient regularly gets migraines and take a pill high in estrogen, they're more likely to have a stroke or frequent blood clots. And I feel like it's the provider's duty to inform the patients of all the risks and thoroughly review their medical history. And then as a continuation, polyp formation in the uterus from oral contraceptives can lead to higher risks of uterine and endometrial cancer. And then contraceptives high in estrogen and progesterone can lead to like increased breast cancer and cervical cancer risks. And then I feel like all women or the women who use contraceptives are at risk, but it's mostly the people who there's like mostly disparities based on like race, ethnicity, and social economic status. And then this is a graph. I think it's pretty like even for like this, but then you can see that black and lower than the white people. And then also I think it doesn't really matter about the education. They're like, and then the next one, it's interesting to see that like only 64% of women are using like contraceptives. But I thought it was pretty interesting that female sterilization is like pretty high because like taking out your uterus and stuff. And I also found that Hispanic and Black women are more likely to sterilize based on pressure or just choices. So what happens to this group? People with oral contraceptives without like proper counsel are less likely to advocate for their productive health and family needs. Unintended pregnancies, birth control complications, and pressure to use birth control are common. For women with lower economic or socioeconomic status and low health literacy, and even like a minority status, can recount experiences of less patient-centered communication, and they also experience feeling pressure to use birth control to maintain family size. And then why is this important? Women's reproductive health is like put on the back burner in America, and it's like pretty important for women to like have the power and the knowledge to advocate for their rights and their health. And I feel like it's like there's unnecessary complications due to like lack of informed consent and shared decision making. Because women are facing health rights with, or like limiting health rights with the draft to overturn Roe versus Wade, it's important for women to be like knowledgeable of the risks and benefits associated with birth control. And then for communicating the risks and using informed consent, that it's the provider's duty to tell the patients of the drawbacks, advantages, and side effects of birth control. And I feel like patients should be able to consider all the risks and options, and there should be like multiple conversations about birth control to make sure that the birth control that the doctor is prescribing like fits for the person, so that all of the medical history is outlined. As a woman, I would like to see more transparent and ethical communication. The communication should be patient-centered and empowering to patients regardless of their choice. Patients should ensure that, or providers should ensure that patients understand everything and are able to ask questions. Providers should be attentive, respectful, empathetic, show a genuine care, and ensure the patient's privacy. Education-wise, I feel like providers should give patients like additional pamphlets and websites to go like in between appointments to further expand their knowledge. I found some good ones on Planned Parenthood and on the CDC website. And then the providers, from the provider perspective, they're reliable, or they're liable for negligence and the outcomes caused by that. And I feel like lack of informed consent is considered negligence, and they can be like sued and just lose their license and stuff like that over like not telling all the patients all of the risks. The definition of informed consent says that patients have to be fully aware of the treatments, risks, and benefits, and you can miss like a little risk or whatever, even if it's highly unlikely, and it can be like detrimental to the patient's care and health. In conclusion, women knowing short and long-term risks, benefits, and options of using birth control is a right. Providers are responsible for informing the patients and empowering each individual to find the best fit. And then the people affected by the lack of communication are women 15 to 49 years old, race, ethnicity, and social economic impact, women more based on finding more proper birth control and weighing the risks, transparent communication, and giving extensive information is beneficial for informed consent. And then here's just my works cited page.
Thank you, Emily. This is, of course, a very timely and important topic in the context of the draft on Roe versus Wade, as you identified in your presentation, right? And I think as well, when we're thinking about birth control and options available, I think that the way that you were focused on informed consent and about just the lack of knowledge that might be given by providers on that issue is a really important topic, right? We can say that there's access or affordability toward birth control options, but if we don't know how to properly use those or what some possible side effects are or what options make the most sense for that person, right? Then they're not able to utilize those resources to the best of their ability. So I think that identifying some of the gaps there and also thinking, as you bring up from a provider's perspective, how that communication can be improved and how we can make sure that informed consent is provided is crucial. So I think you did a great job here of helping us to think about these disparities and also to think about how really providing that informed consent and detailed information is an important way to make sure that while we have those resources, that they're able to be understood and utilized to the best of their ability. So we have two more presentations for today. We'll be hearing from Christy next. So hear from Christy and then Kiana. So you're welcome to click here and then use the arrows.
Okay. So, sorry.
Okay.
Okay. So I'm going to talk about how Hispanic women are diagnosed with cervical cancer at higher rates. And like Fatima mentioned, in the Hispanic culture, we don't really talk about these things or like even mental health. It's kind of like, I don't know, we just don't really talk about it. So I thought it was important. So what are healthcare disparities? And then health disparities are preventable circumstances relating to individuals' health status based on social factors such as income, ethnicity, education, age, and gender. And then what is cervical cancer? A malignant tumor of the lower part of the uterus that can be prevented by pap smear screening and HPV vaccine. So some symptoms and signs are blood spots or light bleeding between or following periods, menstrual bleeding that is longer and heavier than usual, bleeding after intercourse, dutching or pelvic examination, increased vaginal discharge, pain during sexual intercourse, bleeding after menopause, and then this chart just kind of shows like the different types and the symptoms. Understanding the problem. So Hispanic women have the highest cervical cancer incident rate of any racial ethnicity group in the US. And the incident rate is about 44% higher among Hispanic women compared to non-Hispanic white women. And low English proficiency is a barrier to receive a recommendation for pap smear among Hispanic women not up to date with cervical cancer screening. I think this is really important because sometimes when you don't know English, like it's really hard to even understand what people mean. And I know when I've gone like to doctors with my mom, like she'll just like nod her head, like be like, yeah, yeah. And then she'll be like, what did they say? And then I'd have to explain everything to her. And then Hispanic women have lower screening rates when compared to non-Hispanic white women and are even lower among uninsured US Hispanic women. And that's also another big thing. A lot of people don't have insurance. So they're kind of scared of how much it's going to cost. And then Hispanic/Latino women who have been in the US for less than 10 years are significantly less likely to have had a pap test in the last 3 years compared to those who have been in the country for 10 or more years. 88% of Hispanic and Latinas in the US have had cervical cancer screening compared to 95% of non-Hispanic whites. Despite having one of the highest incidents of cervical cancer, Hispanic and Latino women undergo significantly fewer pap tests than non-Hispanic white and Black women. And then, oh, there's videos in this, but I don't know why they're not popping up. Oh, okay. I think it's just taking some time. There's another one that I was going to show. Okay. So I was going to show this one first because it kind of explains what it is like to get a pap smear with that screen.
I was on my way to cervical screening. Not exactly something to look forward to. At first, I didn't think I needed to do this. I was worried it would be really embarrassing, but my friend said it's really important. It can prevent cancer. And my girlfriend said she'd come with me, so I thought, let's do it. When I got there, I was nervous, but the nurse was really nice. She does these tests all the time. I had to take my jeans and pants off and lay down on the bed with my knees up and my legs open. The nurse put something called a speculum into my vagina to help her see the cervix and used a small soft brush to take the sample. I thought it might hurt, but actually it was only a bit uncomfortable. That's it, all done. Are you okay? It was all over in a few minutes and then I went back to work. They'll send me a letter with the results. And if they do find abnormal cells, they can be treated to stop cervical cancer from developing in the first place, which is definitely worth it. I'm not scared of it now. If you're not sure that you need to, just think, if you've got a cervix, then cervical screening is for you.
And then I also wanted to show one more.
Oh, this one. Okay.
And then,
In 2018, over 300,000 lives were lost to cervical cancer, and the problem could soon be much worse. But right now, we can come together to eliminate this cancer for good. If by 2030, we can have 90% of girls vaccinated, 70% of women screened for early signs of cancer, and 90% of patients receiving treatment, in the coming years, we can save millions of women's lives. Each one a daughter, a partner, a mother, a friend. Together, we can create a cervical cancer-free future.
So if you click on the little icon that's right at the bottom right there, to the right of the little Zoom icon.
Oh, this one.
Yeah, yeah, yeah.
Oh, okay.
The one at the end.
Okay, so it took way too much time. Okay, so the vaccine, the HPV vaccine protects against all types of HPV that most often cause cervical, vaginal, and vulvar cancers. The HPV vaccine is recommended for preteens and aged 11 to 12 years. It can be given starting at age 9. HPV vaccine also is recommended for everyone through age 26 years if they're not vaccinated already. And then increasing screening and HPV vaccine rates, providing timely access to diagnosis testing and improving access to comprehensive quality healthcare coverage and cancer treatment care all important in decreasing cervical cancer mortality in women. And then some support groups I found are the Esperanza and VIDA program, was developed to increase awareness of screening methods among Latinas. The health advisors, cancer survivors are trained to develop the program and use a narrative communication approach to promote breast and cervical cancer awareness and screening. The American Cancer Society Cancer Action Network has made significant progress in improving access to cervical cancer screening, HPV vaccination, and treatment for all the Americans at both federal and state levels. And then the Center for Disease Control and Prevention provides uninsured and underinsured women to access to no-cost screening, diagnosis, navigation, and education and outreach services, as well as a pathway to cancer treatment. More than 288,000 Hispanic Latino women have received Pap tests through this program. And then these are just my sources.
Thank you so much, Christy. I really like the way that you're highlighting sort of the impacts related to disparities and preventative care, right? We've talked in this class about how preventative care is not only cost effective, but it saves lives and ensures that if somebody's able to get a cervical cancer screening, right, that they're able to be covered and supported, but that things such as language barriers, access, services, and just communication about preventative health can really allow populations to fall through the cracks. So I really like the way that you incorporated those details to help us understand how this disparity is taking place, and also providing these examples of forms of support and networking that are able to raise awareness about those issues. You know, videos like the one that you shared are great ways for people to kind of demystify, right? The cervical cancer screening is not this scary or terrifying experience. It's, you know, relatively painless. And so the ability to kind of communicate about and discuss what that experience looks like and how that experience can affect people, I thought was really effectively done for this presentation. So thank you for getting us thinking about this topic. So our final presentation for today comes from Kiana. So I just up for you. You can use this here to click and then move through the arrows right there.
Looks like I'm the green. Okay, cool. So today I'm going to be talking about Native American and the healthcare disconnect in regards to rehabilitation programs and resources. There is a big drug and alcohol abuse epidemic in the indigenous communities, and that is due to many factors such as geographical location, low income, and cultural barriers that revolve around tribal lands and reservation systems. So I wanted to do a little bit of background on Native American statistics. 5.7 million people are classified as Native or American Indian or Alaska Native, and that makes up about 1.7% of the US population. 84.4% of Native American children have received a high school diploma, in contrast to 93.3% of non-Hispanic whites. So there is a little bit of a gap there, but I don't think it is enough that where it is causing health disparities. Median household income for Native Americans is $49,000 in comparison to $71,000 of non-Hispanic whites. And then there's 20.3% of the overall population is living at the poverty level line, whereas in comparison to non-Hispanic whites, that's only 9%. And right there is probably the biggest gap that you'll see in statistics is the poverty level. There is a large amount of American Indian families that are struggling with this. And then I wanted to do some indigenous health statistics as well. 14.9% of Native Americans have no health insurance coverage compared to the 6.3% of non-Hispanic whites. And then indigenous people do have high risk health factors, including obesity, substance abuse, diabetes, liver disease, and hepatitis. Also, there are 574 federally recognized tribes in the United States. There are also state recognized tribes. There's about 100 of those. The difference between federally and state is that federally recognized tribes do get provided with health assistance through government programs, which is the Indian Health Service. And then also, like I had reviewed before, there are a lot of cultural barriers and also issues of geographic location, inadequate sewage disposal, and low income. So this is a graph that I wanted to pull up because I wanted to get more of a local perspective of the alcohol issues that we are having. So this is actually from Umatilla County, which makes up Pendleton and Hermiston, and also the Confederate Tribes of the Umatilla Indian Reservation also resides in Pendleton, outside of Pendleton. So their population makes up some of this alcohol consumption. And as you can see, the difference between Umatilla and Morrow County, there's a lot more binge drinking within the Umatilla County than there is in Morrow. You can see that at the 41% versus the 38%. And that is when you are drinking for 3 or more days within a week, and then also 5 or more drinks in one sitting. 53% of adults in the Umatilla and Morrow counties report drinking at least one alcohol beverage a month. And then 1 out of 6 adults were considered frequent drinkers. and that's average of 3 or more a week. And then 23%, which is nearly 1/4 of adults in the Umatilla and Morrow County, are considered binge drinkers, which is, like I said, having 5 or more drinks on occasion. All right, so I wanted to talk about some barriers to the rehabilitation facilities for Indigenous peoples. Indian health services are provided on tribal land. However, less than 30% of Native Americans actually reside there. So that makes up 70% of other Native Americans that do not reside on the tribal land. They're not being able to access these services. Rural communities also don't have access to certified facilities, as well as a lack of transportation. If you look at nations like the Navajo Nation is huge and spreads all throughout Arizona and I believe parts of New Mexico and a few other states. But that is one of the biggest examples of a very rural community, and there's not a lot of resources out there. Also, Indian Health Services receive the least amount of funding from other healthcare programs. So Medicare and Medicaid get a lot more funding than the Indian Health Services. And then also there has been a lot of past historical violence and abuse that has led to distrust in government source medical facilities. So this is the mistrust between tribal and non-tribal members that has risen due to historical events. And then also there is a lot of negative stigma concerning addiction, especially on Native American lands. There's a lot of stigma that and stereotyping that Native Americans are alcoholics and they have issues with substance abuse. And so that negative stigma causes them to not receive the help that they need. All right, so this is my visual aid example of a web. And the end right here is, this all ends in no collaboration. So these are some reasons why there's no collaboration between tribal and non-tribal members in getting the help that they need. And this can be both clinical or rehabilitation. And the couple of examples I have on here. So it all starts with states believing that partners should come to them. And that the people that do not live in urban areas cannot travel, and then they also won't travel to the tribes due to the geography, which leads to lack of face-to-face connection, lack of personal relationships, and then in the end, no collaboration. And then another example of this is lack of cultural competence, historical mistrust among tribal and non-tribal governments, lack of understanding of how tribal governments work, which leads to no collaboration. Okay. So these are some strategies on helping Native Americans receive the rehabilitation that they need, and also just clinical help. This is what healthcare professionals can do that aren't very educated on this topic. But just simply understanding the history of Native American and Alaska Natives and understanding the deep-rooted historical trauma, recognizing different tribal government structures, because there are multiple, acknowledging differences in cultures and traditions between tribes, establishing trust within tribal communities by building relationships, developing communication skills by maintaining patterns relevant to each tribe, and seeking tribal consultation and knowledge. So a lot of this is just education, learning to seek, discuss, and consider advice, and then also understanding key definitions that have significance to tribal members, concept terms, and definitions. Thank you.
Thank you so much for wrapping us up for the day, Tiana. I really appreciated how you were able to integrate some of the local examples and applications, including from tribes in the region and how tribes, including the Umatilla tribe, are impacted by rural factors, lack of transportation facilities, and other kind of structural impacts, as well as the statistics that you provided on some of the challenges related to health, alcohol, and other issues, right? I think in thinking about sort of Indigenous and Native American approaches for health, right, there's such an array of different tribes, experiences, and stories that we need to incorporate. This idea that it's not a one-size-fits-all way of providing care, but of really thinking about and applying this in a localized way to the specific concerns facing regions and tribes, I felt like was something you were able to really speak to effectively here. So thank you for presenting. And again, thank you to everybody on completing these presentations. Again, as I mentioned last class, I am really impressed with the work that you all put in, the way that you're applying and using this material and thinking about this for the class, right? I think these have done a great job of helping us look at health disparity issues, thinking about these topics and showing them in an engaging way. So I also really appreciate the number of folks that were able to attend, even on days where you weren't presenting. I think we really benefited from having you here and listening and learning from what folks in the class have been working on. So thank you for doing that. So I will have your grades and feedback on these by the end of next week, and I'll be working through them in the days ahead. As we gear up for next week, we'll start to look at policy, right? In what ways, now that we've identified disparities and other issues, have we been able to develop specific actions to address some of these topics? Obviously, health policy is super relevant in the context of this road draft. So we'll be looking at and applying current events and other topics to health policy related issues. So have a great rest of your week. Enjoy what will hopefully stay as sunny weather. I will be visiting my partner in Utah who just graduated with a PhD in political science. So I'm very excited for her. Have a great rest of your week. And again, thank you for your thoughtful and engaging presentations.